fibrillation. So first of all, for certain types you need to know about the atrial fibrillation. What is this? First is first episode. That's very important. First episode of atrial fibrillation. This is very important. And in questions multiple times, it can be a first episode. It can also be first time diagnosed. These two are different. These two are different because in first time diagnosed, you don't know the duration. It may be the first episode, it may be the first time diagnosed, the patient may be having it for years, months, whatever. So here you have to be a little bit, mm, uh, I mean, little bit cautious. Now, second area is the recurrent episode. So basically, when we can see, call it a recurrent AF, if episodes are two or more than two, basically. Occasionally, what happens? Occasionally, what happens? AF is happening and AF is terminating spontaneously. AF is terminating spontaneously. So in that case, we call it paroxysmal AF. Paroxysmal AF. And I would suggest if you are free, you can simultaneously take written note that actually helps. Usually, paroxysmal wave, usually they get terminated within 24 hours. But some book says that within 7 days, if it is terminated, we can still call it paroxysmal wave. AF. If AF is not being terminated, so AF not being terminated by itself, so in that case, we call it persistent wave. We call it persistent wave. These terminologies are important because you will find options with this. And usually, before calling it a persistent wave, check it whether it is ongoing for more than 7 days. So timeline you will be getting in the question. So that is very important. Now, there is another AF where the confusion comes. A persistent AF which is not terminated by spontaneously, or even either spontaneously not terminated or by intervention not terminated. Intervention, it can be a cardioversion. Cardioversion can also be a chemical cardioversion, or it can also be a medicine or electric, whatever. But it is no way, by no known natural, abnormal, unnatural way, you cannot terminate it. Then we call it permanent AF. We call it permanent AF. And a patient can easily live with permanent AF, even in case in very elderly patient, permanent AF is compatible with life. Now, why permanent AF is compatible with life? Here, a little bit of clinical sciences. If you think of the cardiac cycle, think of the ventricular filling. So 75% of ventricular filling occurs due to ventricular recoil. Okay. And last 25% of this filling comes from the atrial force. So this is the atrial force. That is only 25%. In AF, what happens? There is no atrial force, or atrial force is gone. It may be there, but a fibrillating atria is definitely not as strong as a contracting atria. So therefore, this 25% is gone, but still this ventricular filling is present. So simply with AF, a person can easily leave. Try to understand. With AF, a person can easily leave. Now, where are the problems? Problems may arise if this ventricular filling is also low. Can happen if the patient is already having LVH, if the patient is already having CAD, if the patient is having ischemic ventricle, anything. You just think. So in that case, what will happen? This 75% is also not there. So slowly the heart goes to failure. So there's a further increase in chance of heart failure from this AF. So that is one area why AF gets complicated. Second area of why AF gets complicated, again from the basic sciences, need to think of the rheology. What is rheology? The flow, the fluidity, the physics of flow basically. So what happens? Whenever a person is transmitted either from sinus to fibrillation or the vice versa, fibrillation to sinus, there is gross changes in rheology, gross changes in turbulence, and gross changes in Reynolds number. Remember. So since these things are happening, there is gross changes in blood flow. So whenever this basic abrupt change in blood flow, this is the point of creation of thrombogenicity. Creation of thrombogenicity. So remember, during this abrupt change, sinus to AF or AF to sinus or persistent AF, all these are actually thrombogenic. Thrombogenic. So basically, the second area where AF complicates the matter, that is thromboembolism. These are the areas where AF can complicate the matter. So then it comes to our idea, try to get this idea that definitely we should not be very aggressive with AF in all the scenarios. Try to understand. Some scenarios definitely require some aggressive management. Some scenario we can keep it a little more lenient, because our problem is if the heart is okay, other areas are okay, it's a chronic kind of an AF, the patient can still live with some protection against this area. Okay. Now coming to, so this was the gross basic thing. Now we are moving on. We need feature. Again, you can get questions where you will be getting some clinical features only. And also, let me tell you, make your mind very differential diagnosis oriented in the examination. Whatever scenario, right from the part one up to the passes, whatever scenario is given, think in a DD way. That means 4 or 5 DD. Approach any question with a DD, with a list of DD kept in mind. Only then you will be successful. So what are the clinical features? It can be SOB, definitely it can be palpitation. In fact, palpitation may be the first one. It can occasionally also be chest pain. Okay, and the sign that is very, very important, which is almost invariably and irregular pulse, or invariably and irregular pulse. So here comes our diagnosis. How to diagnose? Definitely ECG is the thing which we need to through which we diagnose it. So what happens in ECG? ECG simply, you remember, P wave absent and RR interval is irregular. That's very important. RR interval is irregular. If we think a little more, usually we get a narrow RR interval, unless narrow RR interval, unless below down bundle branch block is present. Bundle branch block is present. Once again, since this is the first class, always remember wide RR means something is happening in the ventricle, because R is, or wide R means wide QRS, what we are mentioning basically. So wide, sorry, this one not, I mean narrow R wave. You remember narrow QRS wave. Sorry, I'm so sorry. So wide R means there is some problem down the line. So his Purkinje fiber and down, there is some block. Only then we will be getting a wide something. What is wide? More than 120 millisecond. Anything above the ventricle will be having, any block above the ventricle will be having a narrow R wave. R means QRS. So it will be less than 120 millisecond all the time. Remember this one. Okay. Now coming to the management of the AF. So management of the AF, basically there are two things that we need to think of. So first, whether we need to control AF, and the second, whether we need to reduce risk. This is the management. Now control AF, if you think of the controlling of AF, there are two options by which we can do this. One is the rate control, the other is the rhythm control. And if we make it a little more accepted, rhythm control is nothing but conversion to sinus. Conversion to sinus. Rate is nothing. Rate is reducing the heart rate. It will still remain in AF, but the heart rate is reduced. So most of the symptoms will be reduced, like palpitation. Occasionally, as palpitation is there, your cardiac oxygen demand is high. So you are more prone to ischemia. These things are down if you control the rate, and also failure risk is down. basically. Now, question comes: whom to whom to go for rate control and whom to go for rhythm control? This is a very important question. Usually, usually rate control is taken if the patient is more than 65 years of age, and if already existing cardiac disease is present, usually already existing IHD, ischemic heart disease, is present, we go for the rate control. Rhythm control, try to understand the basics. Your heart is okay, you might be having some regulatory electrolyte disturbances or some reversible problems, you are young, it's better to go for the rhythm control. That means there are still chance. But whenever it is rate control, that means it is more or less hopeless. You are more than 65 years. You are not a sportsman anymore. You don't require that much efficiency of your heart. So we can keep you in AF. Only we will just manage the rate. That's the idea. And already you have some injury in the heart, some ischemic injury in the heart. So already ICMP is there. So there's no point in going for rhythm control. We can keep you in rate control only. Now, rhythm control usually young patient. Young patient, by young, it is 65 years or less. If the patient is very symptomatic. Again, this is some vague thing, point to point and patient to patient you have to do. If it is first presentation, definitely if it is acute A first presentation, we can go for that. And if it is if due to a reversible cause. So definitely suppose dyselectrolytemia is causing AF or hypoxia is causing AF. So reversible causes. So then again rhythm control is actually administered. Okay, and this is the basic way by which we can go for treatment. Okay, so that's the basic identification of the treatment. Now we are coming to how we achieve rate control, how we achieve or how we can achieve rhythm control. So usually rate control medications are simple. We can go for beta blocker or we can go for calcium channel blocker. Now, calcium channel blocker means which calcium? That's a rate limiting calcium channel blocker. So, usually verapamil and diltiazem. So, dilzem, verapamil, we might use. Before using calcium channel blocker, it is better to check low left ventricular ejection fraction. Uh, it's not very outright contraindicated, but always remember be a little cautious about CCB. These CCBs, if EF is very low, because then the positive inotropic facilities will also be gone. So there might be certain issues if we use CCB in a very low EF. Otherwise, it's okay. But that's and remember this knowledge will also not be tested in part one. Only names and approach will be tested in the part one. So these are the option. Now, what happens? Suppose one drug is can't achieve rate control. What we can do? We can add second drug. So basically, our target will be a beta blocker first line, calcium channel blocker second line, and we can also go for digoxin. If one is not working, we can add two or three. Here comes a counterfeit idea is from our MBBS days, we always have read that beta blocker and these calcium channel blockers should not be combined. But remember, it can be combined under on a specific condition when there is refractory tachycardia. We can combine it. But there are certain ifs and buts. Definitely, left ventricular ejection fraction has to be checked. There are, and I have seen patients where very high dose of beta blocker metoprolol 100 is ongoing, simultaneously verapamil 80 40, calaptin 80 ongoing, and the patient is still occasionally complains of palpitation. She is a 75-year lady and she works simply. So this can be done. Theoretically can't be, but this is done most of the time. So these are the things. And when we can't give beta blocker, definitely the beta blocker, the patient is having asthma or something like that, so we can't go for that, and you know all those things.